بسم الله الرحمن الرحيم. It is my pleasure today to discuss with you glucomatous optic disc changes. And this is very important lecture because, as you know, that majority of even investigation you are doing, sometimes you cannot depend on. Yani sometimes the patient is not cooperative to do visual field. There is a lot of fallacies in OCT now. As we know before, they mentioned about the red syndrome in OCT. Now they start to talk about green syndrome. And even when the OCT became green, sometimes it gives you errors, and maybe there is glaucoma changes. And this is the importance of checking the optic disc carefully. As we know that glaucoma is optic neuropathy or optic nerve damage, and according to European Glaucoma Society, they define it as retinal ganglion cell death. And this manifested by, as we know, visual field, it changes. And as we know, intraocular pressure is not necessary to be high in all cases of glaucoma. So the patient may be completely normal, and by time when there is death of retinal ganglion cell, which we call it apoptosis, then the patient will change to undetectable nerve fiber layer. It changes. Then by time these changes will be detectable, and to detect this, either to do investigation or to go for visual field analysis. As we know, there is octopus visual field and Humphrey visual field. And we know that octopus can detect early changes, and Humphrey will detect you the visual field changes late. So usually the structural loss detected early before function loss. You should put this in your mind, and this is rule, and sometimes the rule is not applied. But put in your mind that structural loss usually precedes the function loss. When you look to optic disc, to the patient himself, as regard the quality of life, patient of glaucoma, maybe the video is not working here, and unfortunately, anyway, he has a lot of scotoma in front of his field, and that's why the advanced glaucoma is prohibited to drive. And even when he go to market to select some issues for him, sometimes he's confused for the name of the things he want to buy. Anyway, if we look, for example, for this patient, this is the optic disc, this is his fundus exam, and this, you can see there is cupping here. This cup is large. Is it? All of us agree that this is larger cup. But you can mention this is glaucoma disc or not. Sometimes it's difficult to mention this is glaucoma or not. But you can mention there is large optic disc. We know that the physiological cupping can be up to 0.7, 2% of population, they have cup disc ratio more than 0.7. And this is what mentioned in books. So when you see this disc, you may be tell this is normal disc. Definitely better to look with red-free by ophthalmoscope, so you may detect a nerve fiber layer atrophy. This is what we should see if we don't detect any abnormality. You can mention that isn't rule within normal or abnormal. There is no notching here. There is no peripapillary atrophy. I don't know this is glaucoma disc or not. Then you start to investigate this patient. And look, this is in 2005. The visual field is normal. Then when we do OCT for him, see what happened? The same disc in 2005, there is changes here showing that there is early glaucoma disc damage. And this is a visual field, as I told you before, the function loss usually late in glaucoma, and the structure loss is early. In 2009 and 10, the visual field changes start to appear. So if I go back here, you should look carefully for the optic disc. This is the message of this. You should look carefully when you examine an optic disc, and this is the aim of our lecture today. So assessment of optic disc is very important because glaucoma diagnosis depend on the following. Number one, intraocular pressure, nerve fiber layer analysis, optic nerve head assessment as we mentioned, as well as visual field. What is the problem of intraocular pressure? There is limitation of intraocular pressure in diagnosis of glaucoma. Why? Because the corneal thickness affects the accuracy. We know that thin cornea will underestimate the intraocular pressure. Thick cornea will overestimate the pressure. And as we know also, the patient may come to you in the morning or come to your clinic afternoon, and as we know that there is fluctuation in intraocular pressure. So you may get the lower IOP and mistaken the patient that he has no glaucoma if you depend on intraocular pressure. Again, if the cornea is thick, the patient may present with high pressure, and you may mistake him as a glaucoma and his ocular hypertension. The same for normal tension glaucoma with low corneal thickness. What about the visual field? There is also limitation of visual field because it is subjective and high variability and poor sensitivity. And as I mentioned before, that a large number of retinal ganglion cell layers should be damaged before this is the function loss before late before the visual field changes appear. 50% of optic nerve fiber layer lost prior to visual field defect. Again, this will reflect the importance of looking carefully to the optic disc. So early glaucoma can be missed if the clinician rely mainly on visual field and intraocular pressure, and assessment of optic nerve head and nerve fiber layer are needed in early diagnosis or for early diagnosis of your patient. So what is the rules in assessment of optic nerve? So when you look first, look to the rim, then look to peripapillary region, look for nerve fiber layer, and as I mentioned, this better by red free, and look the lamina cribrosa, which you call Susanna sign, which is widened pores of lamina cribrosa, and look for optic disc hemorrhage. Let us go one by one now. This is the optic disc, and this is the scleral ring. This is the cup border. And we know that what is the rim width is the distance between the scleral ring and the location where the vessel is bent. This is called the cup border. And this is the superior, temporal, nasal, inferior, and temporal. This is the width or the rim. So now this is the border of the disc, and this is the border of the cup. And you can mention here there is cupping. This is the normal cupping of the optic disc. Inferior rim, temporal rim, superior rim, nasal rim, and this here you can talk about what we call it isn't rule. Everybody, I think you know what is isn't rule, that the inferior rim is thicker than superior, thicker than nasal, thicker than temporal. This is for the normal disc. When isn't rule is not applied, so you can tell that this disc is glaucoma suspect. What about the color of the rim? You can see here. Look here, this is the kink of the vessel, and this is the border of the cup, and this is the vertical elongation of the cup. Usually we are looking more. You can look for the horizontal cupping, but mainly we are looking for the vertical because basically the defect occur in optic disc with glaucoma damage in superior and the inferior rim. So we are looking when we estimate the cupping. If somebody asks you what is the cup disc ratio, so mention the vertical cup. You can mention the horizontal, but mainly the vertical cup. So here if you look that the cupping equal to pallor in this slide, and if the cupping equal to pallor, so most likely this disc is physiological. If cupping equal to pallor, so most likely this disc is physiological cupping. But if pallor is more, if you detect that the bell area more than the cupping, so most likely this is neurological defect. And if the cupping is more, so in this case the patient is glaucoma. So look for this disc. You can see that the generalized pallor of the optic disc here, and you can see the cupping only in the middle here, which is about 0.4 to 0.5. But the rest of the disc is pale. Look, this is the cupping and this is the pallor. So most likely this is non-glaucomatous optic neuropathy. Look for this slide. This is the cup. And there is also diffuse pallor in this case, so most likely this disc is neurological. Here also, as I mentioned, sometimes the cupping is extended nasally, mainly vertically, but sometimes even extended nasally. So look for this because nasal cupping is one of the signs of glaucoma. It is not pathognomonic, but put it in your mind. Look for pallor here. And this is here the kinking of the vessel nasally here. And this can indicate that the cupping is more than pallor in this slide. So here we should suspect glaucoma and we do all investigation as we mentioned. Here this is the pallor. But if you look carefully here for the vessel, see the kink of the vessel, see? So the cupping looks here is more than pallor. So most likely this case is glaucoma. Here also about nasal cupping, as I mentioned, sometimes you have nasal cupping, which is very clear in this slide, and it shows you that this is glaucoma disc. Also here, if you look, there is splinter hemorrhage at the edge of the disc, and this indicates that this patient has severe ischemia, and it is common to occur also in normal tension glaucoma. Look for this one here. What is this? Notching. And as we mentioned, in optic disc, there is two pathognomonic signs for glaucoma. All whatever we mention is not pathognomonic except notching. The other one, it will come. Yes. So this is notching here is very clear. And if you see notch, there is no other differential diagnosis of notching in optic disc except glaucoma. And when you see notch, put the ophthalmoscope in red free or put the slit lamp on red free and look with 78 or 90 lens. Look for the nerve fiber layer. You may see this area of atrophy in nerve fiber layer. But if you look for nerve fiber layer first, you may not easily detect it. So if you get notch or suspicion, start to look for nerve fiber layer. And also here there is peripapillary atrophy also. And as you know that it is by itself, it is not pathognomonic, but progression and enlargement of beta zone is another pathognomonic sign of glaucoma. If you look here, the nerve fiber layer atrophy is clear here in this slide, corresponding to an early notching here. And the inferior also, you can see the arrow of nerve fiber layer atrophy. For peripapillary region, as we mentioned, there is two zones around the disc, and usually you see this in myopic fundus. Not all fundus you can see the peripapillary atrophy. We have two zones, alpha zone and beta zone. Don't be confused about alpha and beta zone. Beta, in Arabic, beat. beta. This is your home. So beta zone is close to your disc, and alpha is the one away. يبقى alpha zone is far, which is pigmented, this one, and the beta zone close to your disc or your house, which is beta zone. So beta zone is the one we are looking when it is enlarged by time. This is basognomic. How you know beta zone enlarged? Photo, excellent. So it is mandatory when you have a patient for first time in your clinic with peripapillary atrophy or glaucoma suspect is to send him for disc photography. He may be followed by other team or other consultant or other hospital. So disc photography is very important because it will be an early picture for patient in which when you do another picture, you may detect that there is enlargement of beta zone, and this will be another pathognomonic sign to detect glaucoma. This picture is very clear. You can see very large cup here. This is the alpha zone and circular beta zone. What about if you look for nerve fiber atrophy, as I mentioned, it is difficult, especially when you have advanced glaucoma disease. Because when you have diffuse atrophy, you may not be able to detect that there is atrophy in this patient, because the patient, normal patient, they will have very bright striation, as you see in this slide. And actually, if you look to child, especially hypermetropic patient, to optic disc by direct ophthalmoscope, sometimes you are confused that there is papilledema from the brightness of nerve fiber layer and the crowding of the disc, especially in hypermetropic patient. You may mention when you look for a while this is a papilledema or not, but this is a normal striation of optic nerve, which is completely disappear in advanced glaucoma cases. You can see here it is localized. Here localized and corresponding to the notch mainly. But when it diffuse, what is the hint if the patient has atrophy in diffuse case? That the retinal blood vessel which embedded in nerve fiber layer will be prominent. So when you see the vessel, the prominent, that means there is diffuse atrophy of nerve fiber layer. Look here again. There is area of atrophy here. And you can see some striation up. Also here. And this is, as I mentioned, when you have an area of brightness of nerve fiber layer, bright nerve fiber layer. And when you have diffuse loss, you can see a prominent of the vessel, retinal vessels. It is very clear you can see the vessels in the retina because there is no nerve fiber layer between the vessels. Here also, this is normal. You can see the striation, very clear. And when you have diffuse atrophy, there is prominent retinal vessels. And here the disc is very clear that there is advanced damage disc with peripapillary atrophy, with notching, with nasalization of the vessel, and this is very clear characteristic of glaucoma disc. And when you see that disc, don't tell this is glaucoma suspect, I will investigate the patient. There is disc when you look, you mention this is glaucoma disc. There is no other differential diagnosis, even if the intraocular pressure is normal. Definitely sometimes I saw last week in the clinic anomalous disc. Patient came to me as a glaucoma suspect, but the disc looks for me as anomalous disc, abnormally located, there is cupping. And this patient, when I send him for CT and MRI, has abnormal brain lesion actually, in pituitary. See the striation is very bright, and as I told you, try to see any child hypermetropic, you may think that he has disc edema. As I mentioned, laminar cribrosa, increased wide bores of laminar cribrosa. For disc hemorrhage, very important to put in your mind that disc hemorrhage is not pathognomonic for optic disc glaucoma. And there is a lot of patient, he may present you with disc hemorrhage with normal, completely normal disc. So disc hemorrhage is not diagnostic or pathognomonic for glaucoma, except you see other criteria of disc damage, which we mentioned before: increase cup disc ratio, peripapillary atrophy, notching, nasalizations. All these with disc hemorrhage, you can mention that this is glaucoma, but disc hemorrhage in normal disc is not a glaucoma. You can see here flame-shaped hemorrhage, while the disc is also glaucomatous. Normally, the disc hemorrhage usually take 2 to 6 months to disappear. And sometimes you see the patient and you detect another disc hemorrhage, and the previous disc hemorrhage you see is disappearing. And this also hemorrhage indicates severe ischemia in the disc and indicates that the patient has a progressive disease. You can see here the disc hemorrhage. And when you look to other slide, you can see another disc hemorrhage, see here, and this is one start to disappear in this area. Detection of hemorrhage actually is not easy as you expect, and from the first looking you may miss a disc hemorrhage. So if you look for disc and you detect that there is suspicion of glaucoma, try to look for hemorrhage again. Sometimes it missed the injected vessel or dilated vessel or tortuous vessel, like here. And you see here very faint disc hemorrhage, and here also the hemorrhage inside the disc itself. Sometimes it's in the edge of the disc, sometimes inside the disc, and sometimes it is very faint with difficulty to be seen. And also, if you have a patient of normal tension glaucoma, try to look for disc hemorrhage. This, as we mentioned, as you see here, you can see that the hemorrhage is very minimal, close to big blood vessel, so it is easy to be missed here. And here also, see, adjacent to blood vessel, very difficult and not easy to detect the disc hemorrhage. So if you look to this slide, isn't rule is not obeyed. You agree? We mentioned before that isn't rule, the inferior rim is thicker than superior, thicker than temporal, thicker than nasal, but here definitely it's not obeyed. And also, there is large cup disc ratio, very thin rim here. You can see the notching superior and the inferior, and this is very typical picture of glaucoma disc. What about this disc? You can see that the disc diameter here looks smaller. There is cupping, but you may think that this is also small. No, for a small disc, when you have the cupping is not that large, it's considered large cup compared to a small disc. So don't miss, if you have a small disc, you will not have a very large cup. It also be comparable to the optic disc diameter itself. So here you can see peripapillary haze atrophy. You can see the haze. You can see narrowing of arterioles, generalized atrophy because of prominent blood vessels, and the large cup in a small disc. When you have large cup in a small disc, so it is high suspicion of glaucoma. How to know this is small disc or large, we'll mention in the coming slides. The most important actually, which you confuse all of us, and it is a difficult point in diagnosis, actually is a high myopic patient. It's very difficult. Especially most of them, they present in a pressure in 21 to 20. And you don't know this is glaucoma or not. And that's why myopic patient, we are not depend only on optic disc appearance, as I mentioned, but you will depend also in another criteria, which is the risk factor, family history, genetics. Also the patient history, diabetes, hypertension. And you look for corneal thickness. because most of investigation will be biased, like visual field and OCT in myopic patient. Here look to the disc size, very large. You don't know where is the cup border. See when we draw it, this is the scleral ring. And all this around is the peripapillary atrophy. So sometimes in myopic patient, very difficult, even if they have cupping. Majority of glaucoma in myopia, they have shallow cupping. And this shallow cupping sometimes is difficult to detect except you have very good stereopsis when looking with the 90 lens on a slit lamp. So this is the difficulty we have, and the visual field also will be, they have the same picture of visual field of glaucoma. They give bias also for visual field. And OCT, as we know that it is 3.5 millimeter around the disc, they measure the same atrophy and they give you false also positive findings that the patient is glaucoma. See the cup border? So what is the problem of the size of the disc here? Look for here for this disc. This is the disc diameter, and this one is the cup. This disc is large actually, so if you have large cup in a large disc, so this is not a glaucoma suspect. Definitely you will go and investigate if you are suspect something, but when you have large disc, expected to have large cup. And the isn't rule is obeyed here. Cup is equal to pallor. There is no any signs of glaucoma here. There is no notching, nasalization, vertical elongation, thinning of the rim. Everything is fine. So most likely this cupping is physiological. So how to measure the optic disc? You know this is large disc or a small disc. You know this aperture of the direct ophthalmoscope, which is 1.5 millimeter. So you apply this to optic disc. Here you can see when you apply to this disc, so most likely this disc is normal size. If we go to the other one here, what happened here? Small, because the disc is more. When you go here to this disc, it is not actually put in correct position, but it is actually large size. So the disc here is large. So how you know disc is small or large? Through direct ophthalmoscope. And the average of a small disc actually around or less than 1.5 millimeter. The large disc is usually average more than 2.2 millimeter. Another important point to look for, we mentioned about cupping, peripapillary atrophy, notching, hemorrhage. The other important point is asymmetry. Sometimes patient came to you with normal disc, normal cup, and the other eye, the cup is more. So this is what we call it asymmetry of optic disc. As you can see here, the cupping here is less, here is more. So when you have asymmetry, this is called glaucoma suspect. And again, it is not pathognomonic. But when you have asymmetry of optic disc, you should look for disc carefully to previous what we mentioned, and also to do all investigation to rule out glaucoma. Look for this one again. There is asymmetry. You can see here the cupping is small, here is large cup. So there is asymmetry of cupping. So again, this we call it glaucoma suspect. So here, how to detect progression in glaucoma disc? Look for this patient. This is a slide taken after 10 years. And when we look here to the kinking of the blood vessel here, you can see, and look here, the vessel disappear. That means the cupping is more, and there is progression here in this disc. For this, again, careful observation by disc photography and also by your examination, careful examination on a slit lamp. Again, look here. This patient, this photography taken after 4 years, and you can see the vessel is little straight, little kink here, but the kink here is more and indicate more progression and more vertical elongation of the optic disc cup. And also again, when we see a notching or suspicion of notching, we should look for nerve fiber layer. And you can see here the nerve fiber layer atrophy is increased in the other slide. Again, this is after 5 years. We mentioned that another important pathognomonic factor is peripapillary atrophy. So if you look here, this is the peripapillary atrophy here, and see here the peripapillary atrophy is increased in width. You can see the difference in peripapillary atrophy in both slides. Here again, after 5 months, look for the localized nerve fiber layer defect and also notch here. This is the first slide. You can see this is not notching but early notching, but here when you see here it is very clear starting notching, and the vessel here you can see it is away now, became in the notch itself. So there is difference and there is progression in this patient and the corresponding nerve fiber layer atrophy. This is in 10 years there is enlargement again noticed in nasal cupping here. You can see in this slide this is the cup, but when you look here the nasal cupping enlarged. So also don't forget we are looking vertical mainly, but sometimes the disc change to nasal side, and this is what we call nasalization. It is not pathognomonic, but it's also another sign of glaucoma. Let us go one by one in this following. What is this disc? What do you think? What do you think here? This is a small disc, small cup, and you can see the striation nicely of nerve fiber layer. So most likely this is normal disc. So don't come and tell me we need to do visual field for this patient. I need to do OCT for this patient because I suspect glaucoma. If the patient clinically is normal, so don't waste your time to do unnecessary investigations. And sometimes we have referral by normal disc, and even if the pressure borderline, so no benefit if you do visual test to rule out glaucoma. Look for this one here. What do you think? You can see some abnormality here, is it? Disc hemorrhage. So when I see disc hemorrhage, automatically you look carefully for the optic disc. Automatically you look for peripapillary atrophy, you look for vertical elongation, you look for isn't rule, you look for thinning of the rim. So most likely this is glaucoma. Look for this one. Maybe this is more clear to you. You can see a large disc, and you can see the cupping is more than the pallor, and the isn't rule is not obeyed. What do you think? We'll go back. Large disc. So as I mentioned before, large discs they have large cup. So don't be confused when you have large cupping in a large disc. So most likely this is normal. What about this one? It's very clear here. You can detect the beta zone, notching, enlarged, vertical elongation, nasalization of the vessels. Everything is here actually to tell you that this is, and I told you, you can see when you see this large disc, try to make red freeze of ophthalmoscope and try to look for this. You can see the defect in between an area of striation. So it will be very clear. So this is a glaucoma disc. This is the typical picture we put in quiz most of time because everything in this picture. If you look to this disc, everything in glaucoma abbreviated in this slide. You can see the peripapillary atrophy, you can see the disc hemorrhage, the notching, the elongated, vertical elongated optic disc. This is typical glaucoma disc. What about this one? There is something very clear here if you look. You can see the kinking of the vessel, which indicate notching in this area, inferior notching. So very important, when you look and see kinking vessel, you suspect that there is notch in this area, and you put the ophthalmoscope in red free or slit lamp and look for the nerve fiber layer atrophy. What about this one? Isn't rule again is not obeyed here because the inferior rim is not thick. Peripapillary halo inferior, there is inferior notching, and here there is nasal cupping. So don't forget that sometimes don't expect the notching will be only inferior and superior, but sometimes you have nasal cupping and indicate glaucoma. What about this one? You can see the whitish appearance of nerve fiber layer, and the vessel is embedded, not prominent as we see in diffuse atrophy before. What about this one? Small disc, but they have large cup. As I mentioned before, when you have a small disc and the large cup in a small disc indicate glaucoma, because usually small discs, even they don't have any cupping. Sometimes you see them without cupping at all. Look for this one. Isn't rule here is not obeyed. Very clear. You have peripapillary atrophy. You can see the inferior notching. You can see the nasal even cupping there. And this indicates glaucoma disc. Thank you very much. If you have any question, we can discuss. Any patient of normal, I told you last week I received one patient, he has a lot of problem in his brain actually by CT and MRI is recommended for him. Any patient you diagnose him as normal tension glaucoma, you should send him for MRI or at least CT and CT with contrast. Then if they suspect something, they will automatically refer the patient for MRI. This is a routine for patient with normal tension glaucoma because they may have pituitary lesion. Actually, the confusion occurring only in myopic fundus. What you mentioned, usually see in high myopia, in which it's very difficult to delineate where is the exact cupping border. So in this situation, as I told you, you can depend on other factors. You look for intraocular pressures. You can look for corneal thickness, very important. Family history of glaucoma. Then you decide to treat this patient or not. Because visual field will not help you, especially when you have large peripapillary atrophy. OCT will not help you in diagnosis. But you can depend on other factors. Any other questions? If no question, thank you very much. نحطها تاني؟ أنا شلتها.
شلتها؟ ما في كبير. بس عشان لاني صورت بعضها برسل لك اياها عموما كلها فيديو، بس طلع جميل اللقاء. والله طلع جميل.
ما حطيتش حاجه منه من المحاضره الحلوه دي؟
الا حطيت من المحاضره.
لا انا شايف
والله حطيتها.
انت عايز السلايد اللي انت كنت هتحطها؟ انا شايفك كان مصور عليها.
اخر واحده.
لا اخر سلايد حلوه انت صورتها.
صورت اكثر من واحد. وريني اذا في اشياء حلوه ما حضرتها انا.
اخليها لك كده احسن.
ايوه اذا في شيء، لان انا عجبني انك موضح عليها، وانا يتابعني كثير ريزدنت. وفي بعضهم حتى خارج الرياض.
اجيب لك صوره حلوه.
ايوه يا سلام عليك.
يعني لو تحب انت حاجه زي كده ولا ما تحب؟
لوك
مرزق ده مرزق دي حلوه.
لا لا حلوة مرة. ايوه ايوه
يعني دي ظريفه دي.
هذه مرة. سيبالة هذه ايوه. واخذها كذا.
والعرض احسن حلوه
كذا كذا.
حلو.
لأن هم لما يفتحونها كذا. ولا أخذها بالعرض أحسن؟
انا قلت لك بالعرض.
إي خلينا ناخذها بالعرض تقي. لأنها تطلع أوضح. معلش يا أبو محمد بنتعبك معانا، بس إن شاء الله فيها أجر لك. إي بعدين اسمك طالع رهيب. لا لا تسوي كذا. ليش كذا من فوق؟
شوف لك حاجه تحت.
حلوة.
هي دي بتغني عن
ممتازة مرة. أيوة. يا سلام عليك. هذه بعد تأخذ كذا. مرة حلوة.
فيها الوقت. استنى عشان توري لهم الحاجات البسيطه اللي انا كان.
السلام عليك. ايوه نايس. مرة حلو.
يكفي ولا عايز تاني؟ تاخد دي ديسك هيموريدج.
The detection disk requires كذا. ايوه حلو. حبيبي. ثانك يو فيري ماتش. اخر سلايد كانت. اخر سلايد لاني ما صورته. اخر سلايد كانت مره حلوه. احنا مش ما ارسلناها. اخر سلايد قبل الثانك يو ما مداني اصورها.
كم هم 60
ما شاء الله عليك. بس والله كلامك صراحه يا اخي.
من بعض ما عندك دي ولا
بس والله ما كذا. احنا على وقتنا ما كان احد يشرح لنا كذا بصراحه. ما شاء الله عليك.
عايزها دي؟
هي اخر سلايد هذه.
دي اللي قبل الاخير.
انفير. لا ابغى ايوه اوكي.
انا عايز اشيل لك الاسهم دي.
انفير ببلر.
طب حطها كده.
ما لا هي حطيت سلايدات كثير. يكفي حبيبي. الف شكر.
حضرها للMNM.
بسم الله.
بسم الله.
تعطيه دكتور أول ما تروح للسلايد شو سلايد تضغط سلايد شو هنا لا لا هنا ايوه اوكي دكتور بروجيكتور
اوكي فانتاستيك.
هنا دكتور جست ليزر لايت
ثانك يو.
ماشي دكتور توفيق.
هذا فلاش البروفيسور.
ايوه هو تكلمني.
ايوه خلاص. الو هلا بروفيسور. هو
بسم الله الرحمن الرحيم. Good afternoon, everybody. I'm very honored, actually, to be the moderator for the Grand Round today. I would like to introduce Prof. Tabbara, who is actually well known. I have the pleasure to introduce him as the father of ophthalmology. He's my mentor. He tutored almost all the ophthalmologists here. He's the one who initiated the residency training program here in ophthalmology, and it's a well-known, strong program, not only nationally but also internationally. So I was actually thrilled when I came to know that I will be the moderator for this Grand Round. Regarding Prof. Tabbara, as you all know, he is the chairman of the Saudi Scientific Board in Ophthalmology at the Saudi Commission for Health Specialties. He is also an adjunct professor at the Wilmer's Eye Institute of Johns Hopkins, Baltimore, USA. He is a clinical professor at the Department of Ophthalmology, College of Medicine, King Saud University, and he's currently the director of the Eye Center and Eye Foundation for Research in Ophthalmology here in Riyadh. He has over 350 publications. He's also an author or co-author or guest editor in many books and chapters. And he's still continuing, of course, to teach residents, do research, and master the clinical and surgical ophthalmology. He is a recipient of several awards. For the awards, I have to read them through the paper because they are difficult to memorize. The latest one, or the most recent, is the award in teaching and training in ophthalmology of the Saudi Ophthalmological Society during the 3rd Red Sea Ophthalmology Symposium that was held in Jeddah in January. He also received a Life Achievement Honor Award from the American Academy of Ophthalmology at the Academy Annual Meeting in November 2015, Las Vegas, USA. The Gold Medal Award 2011 of the Saudi Ophthalmological Society during the annual meeting in February 2011. He was also awarded the Trachoma Gold Medal of the year 2000 from the International Organization Against Trachoma during the 106th Congress of the French Ophthalmological Society in May 2000 in Paris. And this specific award is only given to one scientist who has contributed to the control of trachoma over the whole world. He also received the Lifetime Achievement Award from the Hellenic Society for the Study of Ocular Inflammations and Infections during their 6th meeting on ocular inflammation and infections in November in Greece. So he's going to talk to us today about the squamous cell carcinoma of the conjunctiva. And apart from all this, I would like to thank him on behalf of all the ophthalmologists here who graduated from the program because he did not only teach us ophthalmology, he taught us self-confidence, ethics, and even how to present, how to prepare presentations. So all the small details, and I guess we all owe him the success that we have achieved so far.
Thank you, Hind, for a very pleasant and kind comments. I would like to say that you called me father, but most of the people called me the grandfather. You are now the parents of the program, and I would like to congratulate you, and I take personal pride in this major achievements in the building of manpower for the Kingdom of Saudi Arabia. Thank you very much, Hind. Exactly 33 years ago, I stood in front of you, in front of people who were here. Most of you were not born 33 years ago. And I gave the first grand rounds of the King Khalid Eye Specialist Hospital. And that grand round was on trachoma in classroom 2 in the hospital. This was next to the old library. And at that time, I didn't think that in my lifetime I'll come 33 years later and give another grand rounds. But personally, I'm delighted, happy, and pleased to be with you and to talk about ocular surface neoplasia. Ocular surface neoplasia is a common disease in Saudi Arabia. And this is why I selected this topic for this grand rounds. It's a disorder that affects the cornea, the limbus, and the conjunctiva, and ranges from dysplasia to invasive squamous cell carcinoma, which can be either life-threatening or vision-threatening. Recent advances in the field of pathology, immunology, molecular biology, and pharmacology have greatly influenced our thinking and contributed to our understanding of the disorders known as ocular surface neoplasia. Over the next few minutes, what I would like to do is discuss the ocular surface neoplasia and then elaborate on the risk factors, elucidate the pathogenesis, describe for you the clinical findings, and finally, I would like to outline the management and the outcome of these patients with squamous cell carcinoma. The disease is vision-threatening and life-threatening. And in Saudi Arabia, squamous cell carcinoma is an aggressive disease. It is therefore conceded that early diagnosis and prompt treatment of these conditions can save not only the vision of the patient, but also the life of the patient. We as medical scientists have the unique role to dispel the mystery of ocular surface disorders and replace speculations with certainty and fiction with facts in an attempt to provide sound, rational, effective therapy for our patient with ocular surface neoplasia. About our universe, very little is known, much less is true. But one thing for sure, the sun is the source of energy and light. And the sun is the source of light, and light is electromagnetic spectrum, which is divided into visible and invisible. The visible photons are between 400 to 750 nanometers in wavelength. Those under 400 are referred to as the ultraviolet rays. Over 750 are called the infrared waves, and they differ in their physical functions. The ultraviolet causes damage to DNA. It does not cause thermal injury, and it does not cause photothermal injury. It causes photochemical injury. And therefore, what it does, it disrupts the molecules, or it can cause damage to the DNA. And this is important in understanding squamous cell carcinoma. And as you may know, excimer laser is a wavelength of 193 nanometer of argon and fluorine excited in a tube and emits a wavelength that we call it the excimer. What it emits is a photochemical reaction. It does not vibrate molecules. It splits the atoms. And therefore, if you have nitrogen, carbon, oxygen, which is the contents of the proteins on the surface of the cornea, these atoms split and the bonds break, and they will get nascent molecules, or nascent atoms that will evaporate from the surface of the eye. On the other hand, the infrared causes vibration of molecules. Vibration increases the temperature, and this is why we call it photothermal damage. We're not going to talk about photothermal. We'll go about the ultraviolet, which is the photochemical injury. Now, the sun is interesting because it is the source of energy on this planet. Our global village is moving at a rapid pace, and major climate changes are occurring. Human activities and the burning of the fossil fuel are increasing the global greenhouse gases, depleting the ozone layer, and at the same time increasing the temperature. Ultraviolet rays become more efficient if you have increase in the temperature. And therefore the danger is not only increase 1 degree or 2 degrees in temperature, but also the danger is the UV light, because they become more efficient when you have a higher temperature. And therefore, the sun as we know it is the source of life. It is the reason for aging and the cause of death. Yes, it is paradoxical, but it is true. The sun is the cause from life to death. And this is depicted in the poem by Shakespeare, where he has all these three stages, from youth, life, aging, and death. And Shakespeare wrote 154 sonnets. This is sonnet number 18, and he's talking to a lover. Shall I compare you to a summer day? Although you are more lovely and more temperate, rough winds do shake the darling buds of May, and summer's lease hath too short a date. This is called the 5-syllabus poem, which is referred to as the pentameter. It's iambic, and the rhyming is couplets. That is, the day and May, they rhyme together. And this poem describes the sun, nature, the summer, life, and aging. And he says, sometimes too hot the eye of heaven shines, and often in his gold complexion dimmed. And the eye of heaven is the sun, which causes the aging. And he says it, and every fair from fair sometimes decline. It is, and the beauty of the youth declines. That is, because of the wrinkles, you will have declining beauty. By chance, in nature's changing course untrimmed, and your eternal summer shall not fade, nor lose possession of that fair thou ost, nor shall death brag those wonders in the shade. And what he is telling us is that youth can be, and the beauty of youth can be ephemeral and fugacious, but love is eternal. And here the summary of life, of aging, and of death. The eye is the organ of sight. Unfortunately, it is the target of insult by light. And ocular surface neoplasia is one such insult on the surface of the eye. Now, we talked about the UV radiation, but we divide it into three parts: the UVA, B, and C. C is the shortest. You can see it is between 200 to 290. And we talked about eczema, only 193. And this is coming from the energy from the sun. This is filtered by the ozone layer, and therefore does not reach us. If it does, we will be hit by eczema laser all the time, because it's very close to the eczema laser. These are rays that cause photochemical reaction. And if we deplete the ozone layer, we'll be exposing ourselves to effects like eczema on our skin. So UVC, fortunately, it's filtered by the sun, by the ozone layer. UVB 290 to 320 is partially absorbed by the ozone. But the one that reaches us totally are the UVA, which are longer wavelength, and they are between 320 to 400 nanometers. These are the ultraviolet rays that makes our skin brown when we go in the sun. It causes migration of melanin into the melanocytes. And when you do that, your skin becomes darker. Fortunately, our skin is protected by the melanin as we live here. Now, what's the effects of the UVA on tissue cultures? And this was an interesting study by Ibuki. He showed that UVA, UVB, UVC, if you take tissue culture and you expose them to this UV light, you will suppress apoptosis. That is, you will allow unrestricted proliferation of the cells. And Izumizawa found out that, if you expose this tissue culture to A, B, and C ultraviolet rays, you will get increase in the mutation frequency. When I worked at the University of California, there was a scientist called James Cleaver, a very interesting guy. He's still living, he retired at the University of California. But he discovered that there are two types of DNA synthesis. One which is scheduled, like all the time we get damage and we get repaired, the damage of the DNA. But when we get exposed to the sun, we get unscheduled DNA damage. Unscheduled DNA damage, meaning that there is more repair of the DNA as we get exposed to the UV light. And this was a major discovery by Jim Cleaver and applied it to xeroderma pigmentosa, as we will see. Now, Dr. Hind Al-Qattan will tell you that there are terms that confuses everybody. And I will like to mention some of these terms in histopathology just to clear it in the outset before we go to the lesions on squamous cell carcinoma. Acanthosis is an increase in the prickle cell layers usually of the skin. Parakeratosis is the persistence of the nuclei in the keratin layers. Dyskeratosis is abnormal layer of keratin. Hyperkeratosis increases the layers of keratin. Atypia, abnormal development, and usually there is mitosis with this. Metaplasia is change in the structure of the tissue, and metaplasia refers to changes in tissues. For instance, if this tissue is supposed to be columnar epithelium and becomes squamous cell types of epithelium, then this is metaplasia. Change in the structure of the tissue. Dysplasia is alteration in size, shape, differentiation, polarity. And this is called dysplasia. I hope we will not intermix them, and these are important pathology terms that we learn from Dr. Al-Qattan. An interesting case came to me referred from the Eastern Province. A 41-year-old male with this lesion. The patient gave history of excising the pterygium done once in Bahrain and once in Dammam. And he had recurrence of the pterygium. But when I looked at him carefully, we found out there is slight elevation here. There is a pterygium, or so-called pterygium, but it has feeding vessels. And the feeding vessels are not horizontal like you see in a pterygium. They are coming from superiorly and from inferiorly. The patient in the history was significant because he gave history of kidney transplantation. And what do you do after kidney transplantation? You give them immunosuppression in order to prevent rejection. What happens when you have immunosuppression? You knock off the T cell and the cytotoxic T cell that's important for the defense against squamous cell carcinoma. And now there is a treatment that upregulates the T cell in order to eradicate the squamous cell carcinoma. So now 41 is not old. Usually squamous cell carcinoma comes in the older age group, but he was in immunosuppression. I asked for the pathology report. What do you think I got? Nothing. Because most people here do excision of pterygium and don't send it to pathology. In Saudi Arabia, I will regard it as a medical legal case if somebody does not send a pathology specimen of pterygium in Saudi Arabia. I think it's must, even if it doesn't look like a squamous cell carcinoma, send it to pathology and be on the safe side. Well, what happened? He said, I told him you need excision. And he said, let me think about it. This was in June 2013. He came to me back in November 2013, and this is how he came. Well, there is marked growth, as you agree, of squamous cell carcinoma with papillary reaction on the surface and evidence of feeding vessels and gelatinous infiltration of the cornea. Well, I told him we have to do it. You cannot because you will risk your life. And we did excision at the eye center here in Riyadh. We did a wide resection of the tumor, and it came out to be squamous cell carcinoma of the conjunctiva. You can see what I was talking about. These are referred to as the keratin pearls of squamous cell carcinoma. There was evidence of mitosis, and you can see the persistence of the nuclei in the keratin, which is the parakeratosis we are talking about. So what we did was excision, and we did conjunctival transplantation, and this is how he looked 1 year later. But because the lesion was large, we gave him mitomycin C, and we gave him 0.02% 3 times daily for 2 weeks, and then 1 week off, and we did 3 cycles. And he stayed without treatment, and this was in March 2014 and in May 2015, showing no recurrence of the lesion. And this is a safe and effective approach that is combining therapy, excision, with mitomycin C. This is a patient came from Qatar, and similar history, 2 times excision of pterygium, and she has a recurrence. It was gelatinous, it was not well defined, so we did excision and proved to be squamous cell carcinoma of the conjunctiva. We put her on mitomycin C because we could not define the tumor. It was so diffuse on the surface of the eye. So we gave her mitomycin C, and she came later with complete recovery, and this was 2 years after excision and mitomycin C without any treatment, showing complete recovery of the squamous cell carcinoma. Now, how about the epidemiology and risk factors? What are the risk factors for squamous cell carcinoma? How about the epidemiology? How do I compare squamous cell carcinoma in Saudi Arabia to squamous cell carcinoma in the United Kingdom, where there is no exposure to UV light? Here we get exposed all the time. We in Saudi Arabia have 5 squamous cell carcinoma for every 1 million. In the UK, it's 0.2 per 1 million. In Saudi Arabia, the male to female ratio is 2 to 1. It's always common in males. And you know why. Most males have more exposure to the sun than females. And females have more vitamin D deficiency than males. At the eye center, we see 1 case of squamous cell carcinoma every 20,000 patients. The incidence of squamous cell carcinoma of the skin increased by 5.5% for every 1 degree Celsius of increase in temperature. And this was a study by Vanderloon in 2008, comparing 5 different regions with different average temperature. and found out for every 1 degree increase, you get 5.5 increase in the squamous cell carcinoma. As I told you, it's not only exposure to UV light, it's also the temperature, because the temperature can make DNA damage more efficient with the UV light. Now, how about the risk factors? And this is one of the most important discoveries of the 20th century. I regard this, the discovery of the human papillomavirus. Human papillomavirus was discovered in 1984, not a long time ago, at the time when we were here at King Khalid Eye Specialist Hospital. In the first year of opening of this hospital, they discovered the human papillomavirus. It used to be called the papovavirus, Papoviridae. And later on, it was split into two families. One family refers to as the papillomavirus, and the other is the polyomavirus. Polyomavirus is JC virus and BK virus, which is a risk for patients undergoing kidney transplantation. The papillomavirus is the one that causes warts and causes papilloma of the conjunctiva. But it was interesting to know that 70% of cases of carcinoma of the cervix are associated with papillomavirus, either 16 or 18. So much so that it was decided that everybody in the United States should have papillomavirus vaccination when they are at the age between the age of 9 and 14. And this is to prevent squamous cell carcinoma, carcinoma of the cervix in particular. So human papillomavirus is an important risk factor for squamous cell carcinoma of the cervix. And there are many reports now that it has been found that to be the cause of squamous cell carcinoma of the conjunctiva. So UV light is a risk factor. Gene mutation. Dr. Hind Al-Qattan and Dr. Hela Hussein did profiling, genomic profiling of specimens from patients with squamous cell carcinoma. And out of 12 cases, they found 9 cases of gene mutation in the Adam group of genes, which is an interesting finding that points out to the fact that gene damage or gene mutation can lead to abnormal growth and therefore squamous cell carcinoma. Defective DNA repair is another known factor in squamous cell carcinoma. Genetic factors like in xeroderma pigmentosa and immunosuppression. We mentioned already a case that a typical example. HIV infection is associated with Kaposi sarcoma, with squamous cell carcinoma of the skin and many other types of tumors because of immunosuppression as well. And it was interesting to note that there are many reports showing that atopy is a risk factor for squamous cell carcinoma of the conjunctiva. This is a 65-year-old English professor who was diagnosed to have chronic allergy because of itching, and he was put on every drop you know, and he was not responding. And this is when he presented to us. And immediately what we did was conjunctival scraping, because we do it on all cases with chronic conjunctivitis. And the patient had mitosis and atypia and abnormal cells in the conjunctival scrapings. Immediately we did a conjunctival biopsy, and this was squamous cell carcinoma of the palpebral conjunctiva. Very easily missed as an allergic conjunctivitis. So this is when you have chronic unilateral conjunctivitis, like this patient, you have to go and take biopsy and don't keep the patient on eye drops until they can get metastasis. A report by Hans and Associates showed that squamous cell carcinoma of the conjunctiva occur frequently in patients with atopic eczema. Now let's move on from risk factors, epidemiology, back to pathogenesis. How does it occur, squamous cell carcinoma? Well, there are several factors that affects the DNA, and DNA damage may lead to squamous cell carcinoma of the conjunctiva. We mentioned ultraviolet rays. There are mutagens that cause DNA damage. Radiation can cause DNA damage. Viruses, and there are 7 viruses that have been identified to cause DNA damage. One of them is the papillomavirus. I will not go over the 6 others, but one of them is the papillomavirus. Chemicals, trichloroethylene and cobalt, are the only 2 chemicals that have been announced by the WHO that they cause squamous cell carcinoma. And there are genetic factors. You will find that certain families having more common cases of malignancies than others, and so forth. Now, back to the human papillomavirus, which is a major risk factor. It causes DNA damage. How does it do that? Well, it's a 55 nanometer papillomavirus. It's host specific. The papillomavirus of dogs does not infect man, and vice versa. The papillomavirus of cats do not cause warts in man. So they are host specific. They are non-enveloped. And there are 370 types that have been associated and recognized. 170 have been sequenced. The incubation period of papillomavirus is 3 to 4 months. But in most cases, it goes up to 1 year. If you scratch your wart now and scratch another place, it will take you 1 year for the wart to go. So incubation period is too long, and this should be kept in mind in the management of cases of papilloma. So it can cause skin warts, it can affect the mucous membrane, cause conjunctival papillomas. There are 2 types of human papillomaviruses, those that we recognize as low risk that can cause papillomavirus and papilloma of the conjunctiva, or the high risk which causes oncogenesis, and these are specifically 16 and 18. By the way, the vaccine which is marketed in the United States, there are 2 companies that does them, and both of them are papillomavirus types 16 and 18. So the high risk group, 16 and 18, express certain proteins and allow the cell to express certain proteins known as E6 and E7 that bind to P53. What's P53? It's a tumor protein 53, which is a tumor suppressing gene and tumor suppressing protein. So this protein suppresses the tumor. When you have a reaction between E6 and E7 and the TP53, then you will have unrestricted growth of the tissue and squamous cell carcinoma. My friend Dr. Kalogeropoulos, he's in Greece, described and by 2 cases of human papillomavirus 6 and 18 isolated from papilloma of the conjunctiva. So when we see papilloma of the conjunctiva, you have to keep in mind that these are benign, yes, but they can become malignant. And these papilloma, usually papilloma of the conjunctiva does not undergo malignant degeneration. But if you excise it, then 6 months or 1 year, you'll get a recurrence somewhere else in the conjunctiva. You can get daughter papillomata. And this is a papilloma of the conjunctiva. This is a patient, 9-year-old girl, came to me from Kuwait with this lesion. She was scheduled to undergo surgery. I told her she should not undergo surgery, just observe. And over a period of 2 years, the lesion disappeared. So with immunity, you can get rid of some of these. If you excise it, you can excise it, but you have to give treatment for it, observe it, and there is a risk of having daughter papillomata on other places on the conjunctiva. Mubayyat have shown that there is high frequency of human papillomavirus 6, 11, 16, and 18 in infections in patients with squamous cell carcinoma of the conjunctiva, suggesting that some cases of squamous cell carcinoma are caused by papillomavirus, like we have in carcinoma of the cervix. What happens? What is the problem that's happening? Well, this is the well-known Watson-Crick helix, and you know from the helix, this is a helical structure, it's double-stranded DNA, and you know that there are 4 types of base proteins. You have the adenine bound to the thymine by hydrogen covalent bonds, and the guanine binds to the cytosine. By the way, the cytosine becomes uracil in the RNA, but in the DNA, you have these binding of the base pairs. Now, when you get exposed to the sun, what happened? Well, you get dimers. What are the dimers? You can get either a cytosine dimer or a thymine dimer. What do you mean by dimer? It means 2 similar molecules. That is, thymine will be bound to a thymine and the cytosine to a cytosine. And what happens then? Then the DNA will have to be repaired. How do you repair it? You have to excise it by endonuclease. Then you have to repair the DNA molecule because the original, it's double-stranded, one of them is damaged, the other is not. And then you have the 2 base pairs, putting it back. You seal it by polymerase. You link it to the helical structure by ligase and helicase. And this is the excision repair, we call it. And this is nucleotide excision repair of the DNA after forming DNA dimers. So you get global genomic nucleotide excision repair or transcription coupled. These are 2 pathways for the repair of the DNA that has been damaged. Well, what happens if the if the DNA is unrepaired? Then you have gene mutation and leading to metaplasia and neoplasia and squamous cell carcinoma. And this is exactly what happened in xeroderma pigmentosa, which is a genetic disease, autosomal recessive, not uncommon here in Saudi Arabia. Maybe many of you have seen cases. The DNA occurs, they cannot repair their DNA damaged. They get thymine dimers, and there is no endonuclease to cut it and take it out. So you get a damaged DNA. You get a mutation. And they have 10,000 times risk of squamous cell carcinoma more than the general population. Now let's go to the clinical findings and look at what are the presentations of squamous cell carcinoma. There is a precancerous lesion. We refer to them as actinic keratosis, epithelial dysplasia, conjunctival interepithelial neoplasia, which we used to call it carcinoma in situ. A tumor does not go beyond the basement membrane, and this is CIN. And you have epithelial neoplasia where you have atypia, loss of polarity, and does not extend beyond the basement membrane. And this is the typical lesion of CIN. This is a limbal lesion growing on the cornea, always starts at the limbus, grows on the cornea because it starts at the stem cells. And you can see this gelatinous grayish infiltration and finger-like projection. This finger-like projection is the sine qua non of this lesion, and therefore you should suspect CIN when you see these finger-like projection into the cornea. So this is CIN. But squamous cell carcinoma itself can present in different format and under different names. It can be leukoplakic, nodular, flat, diffuse, papilliform, gelatinous. And this is the typical form of actinic keratosis. And this is with the whitish plaque, leukoplakic we call it, and you can have it flat, or you can have it gelatinous, invading limbus with feeding vessels, or it can be nodular. So you can have different forms. But even with a pterygium like this, you should submit it to pathology, because sometimes you may have malignancy in some of these cases with pterygia, like it happened in this case, where the patient had excision of pterygium, no pathology specimen, and the patient had recurrence of an invasive squamous cell carcinoma of the conjunctiva. And this is the patient I showed you with diffuse papillary carcinoma, squamous cell carcinoma of the conjunctiva. But this is not at the limbus, this is at the palpebral conjunctiva. How we manage? Well, there are two approaches. There is the medical management, and there is the surgical management. And most cases that I treat, I combine them together. One of the most effective treatment, unfortunately, it's an expensive drug. It's interferon alpha 2B. It's called commercially as the PEG interferon. PEG interferon is pegylated molecule. Pegylated meaning binding the interferon to glycolic acid, and therefore when you bind it to glycolic acid, you decrease the degradation of the interferon. You can inject 10 microgram once weekly for 3 times, or you can give mitomycin C 0.02% or 0.04%. In the literature, 0.04% is mentioned. I prefer to use the 0.02% 3 times daily, because 0.04% may knock off these stem cells. 5-FU 1% can be used for 4 to 7 days. Photodynamic therapy has been reported. I haven't used it. External beam radiation, cryotherapy, and sometimes other modalities such as DNCB, dinitrochlorobenzene, which increases the immune mechanisms and the T cells that allows the control of these tumors. Or there are anti-VEGF sometimes have been tried. I have not used other modalities. And more recently, and this is in the New England Journal of Medicine last November, where they have found out that a biologic known as the nivolumab, and this now has been approved by the FDA in the United States for recurrent squamous cell carcinoma of the head and neck. It's an interesting biologic because it is an anti-PD-1. PD-1 is the molecule programmed death 1. So if you target the PD-1, you increase the T cell that hits the squamous cell carcinoma. So this is an anti-PD-1 or anti-programmed death molecule. And this is an interesting approach. Unfortunately, already from November till now, there are around 5 reports of autoimmune diseases associated with the use of nivolumab. I don't know whether it will continue, but in the most marketing evaluation, we will know whether this is a safe drug for us in ophthalmology or not. We have not used it in ophthalmology, but this is just to give you an idea about the approaches for these tumors. The patients that are reported had either hypoadrenalism or hypothyroidism or decreased pituitary function, and these are autoimmune diseases against the endocrine glands. In general, squamous cell carcinoma rarely metastasizes. Dr. Hind will tell you that, and we used to think that metastasis is probably because of delay in treatment, but Dr. Al-Qattan reported that there are certain types of squamous cell carcinoma that can lead to metastasis. Knee and associate, among 232 cases, they found no metastasis. Zimmerman found 2.3% in their cases of 87 cases of metastasis. And we here at King Khalid Eye Specialist Hospital reported on 10 cases of metastatic squamous cell carcinoma from the conjunctiva. So it can become life-threatening when you have metastasis. And there were mostly males. And these are the sites of metastasis: submandibular, parotid, lymph nodes, bone, and lung. And this is what the report of Shields and the report of Dr. Al-Qattan, showing that metastatic squamous cell carcinoma can occur in certain types of squamous cell carcinoma called the spindle cell-like carcinoma. This is a patient who had squamous cell carcinoma that invaded the globe, and the patient had squamous cell carcinoma that was identified. And this is another patient who had an advanced squamous cell carcinoma, and the patient had, and this one has quite a large, almost like a tennis ball, on surface of the eye, and this patient had metastasis to the lung. So delay in management can lead to metastasis, but also the type of the tumor can lead to metastasis. And this is another patient where the tibia had the metastasis, and this is a biopsy specimen taken from the tibia of the patient showing squamous cell carcinoma. The patient had squamous cell carcinoma of the conjunctiva. This patient had squamous cell carcinoma of the conjunctiva, intraocular penetration, orbital, parotid, and lymph nodes. So you can see that these tumors are not always benign. They are quite serious and life-threatening. Tom Johnson, Bob Weatherhead, Bob Kirsten, Charles Lies, and Amin Nasser, we collected our cases of squamous cell carcinoma here and found out that there were 57 cases, and these were orbital cases of squamous cell carcinoma. And you probably know some of the doctors that reported this. Tom Johnson is in Bascom Palmer in Miami. Weatherhead is now in New Zealand. Bob Kirsten is in San Francisco at the University of California. He is the head of the oculoplastic unit. Charles Lice is the head of the plastic unit in Michigan, and Amin Nasser is in Beirut. So this is a group that we were here when we reported these 57 cases of squamous cell carcinoma. 75% were invasive, 25% were not. This is one of the cases showing squamous cell carcinoma of the limbus, and this was proven by biopsy specimen. We looked at the recurrence of squamous cell carcinoma. What causes a recurrence of the squamous cell carcinoma after you excise it? Old age, large diameter, high proliferation index, and you can determine this by KI67, positive margins, and grading of the tumor. It's usually tumors with higher grades end up in more recurrences than others. If you get a recurrence, it happens within the first year. If you don't get a recurrence within the first year after the excision, then probably you will not get it. And these cases, in all the cases, 7 out of the 9 cases occurred within 11 months. So most of the cases occurred within 1 month. And 5 had invasive tumors with metastasis. That is 8.8%. So this is why when I started at the outset saying that squamous cell carcinoma in Saudi Arabia is different from what you read in the books. In the books, you tell you there is no metastasis. They tell you it's not aggressive. And here we have shown that the tumor can be serious, it can be vision-threatening, it can be life-threatening. And this is a late onset of squamous cell carcinoma. This is another case that required exenteration. And this is the exenteration. And this is a very late case of squamous cell carcinoma of the conjunctiva. And you can see how serious it can be. And in some of these cases, one of the patients died, and 6 out of 10 cases that I showed you ended up in exenterations. And this is squamous cell carcinoma of the conjunctiva. Finally, I would like to conclude by talking a little bit about xeroderma pigmentosa. which is an autosomal recessive disease due to excessive solar damage to the skin at an early age. There is increase in the incidence of skin cancer up to 10,000 times than the general population. And the main problem is a defect in the DNA repair. There is no endonuclease. And therefore, if you have a dimer, thymine, and the DNA cannot replicate, you cannot excise it. And then if you don't excise it, it undergoes mutation, you will get abnormal growth and squamous cell carcinoma. And there is gene mutation has been identified. There are 7 types. These are the most common 2 types of xeroderma pigmentosum, XPA, XPB. And they have inability to repair DNA damage. This is a patient with xeroderma pigmentosa here in Saudi Arabia, and you can see the tumors on her face, and you can see here at the edge, you may see a tumor here. What was this tumor? A hemangioma. So you don't only get squamous cell carcinoma in the xeroderma pigmentosa. You can get any tumor because you can get DNA damage anywhere. And the patient had squamous cell carcinoma of the tip of the nose, on the side of the nose, on the eye, on the tip of the tongue. And the patient had 7 tumors on her face. And these were squamous cell carcinoma. She had a malignant melanoma, and she had basal cell carcinoma here, and squamous cell carcinoma of the tip of the nose. And this is malignant melanoma that she had in the conjunctiva. And these pathology specimen proved this point. And these are the tumors that this patient had. She had to undergo extensive surgical procedure. And this is the tip of the tongue showing squamous cell carcinoma of not only on the eye, but also on the tongue and the skin and other places. And this is another child who had xeroderma pigmentosa that we took a biopsy, prove it, but he had multiple squamous cell carcinoma of the conjunctiva. Do you want to go and excise everywhere? So we did not. And what we did was to put him only on mitomycin C after taking a biopsy specimens. And this is how we looked 1 year later with no lesions. And I saw him 3 years later, and this patient had scarring of the cornea. And we reported a case of scarring of the cornea in xeroderma pigmentosa. Actually, we had 9 cases that we reported. And these cases did not have squamous cell carcinoma. They had diffuse corneal scars and did not have ulcers. And they had scars. So what they did is exposed to UV light, you got damage to the DNA, and you got metaplasia instead of having tumors. So you ended up in metaplasia. Instead of having a keratocyte, you will have a fibroblast. And the fibroblast caused the scarring. And you can see the scarring all over. So in conclusion, we can say that squamous cell carcinoma of the conjunctiva is common, it is aggressive, it is life-threatening, it is vision-threatening. Early diagnosis and prompt treatment are mandatory for the cure of the neoplasia and prevention of recurrences and metastases. Thank you.
Thank you, Prof. Tabbara, for a very informative and yet attractive talk. We have few minutes for questions. I don't think I can add any more, apart from the fact that I would like the residents to check the AGCC book, which shows the effect of the grading of the tumor and the size of the tumor on the prognosis, as Prof. Tabbara mentioned earlier. And you already touched on the spindle cell variant, which is more aggressive. Yeah, Dr. Ali Rashhi, yes?
Thank you, Dr. Khalid, for a very nice, informative and up-to-date. I have a couple of comments regarding presentations. You have alluded very well, but one of the presentations that sometimes we see is a chronic conjunctivitis, similar picture. In addition, as you clearly have shown also exophatic proliferation of the tumor, sometimes it can be endophatic. And I have one case who presented with thinning at the limbus rather than thickening the conjunctiva. That case ended with perforation and recurrences. In addition to that, it can also be present as primary tumor for perforation. This has been reported. I have only one case who had presented as a recurrence in exactly 11 months because he lost his follow-up when he came with perforation after complete excision of the tumor. Regarding invasiveness, I cannot stress that tumor squamous cell carcinoma of the conjunctiva behaves aggressively in the Kingdom of Saudi Arabia, maybe even neighboring countries, but signs of invasion also. When we did the studies, 100 cases, 75% of the cases were invasive. And some of these cases were not only microinvasion, which is just beyond the basement membrane, but they were to underlying tissues such as cornea and sclera. And this needs sometimes lamellar dissection when they are done with, dealt with tumors. In addition to what you have mentioned, regional as well as distant metastasis. All cases that we have with the xeroderma pigmentosa were invasive. None of them were just CIN. Couple of things regarding management. I would stress that any management with just excision to have clear conjunctival margin, what appears to be normal, like 1 or 2 millimeter, and then also combined with double freeze thaw cryotherapy, which probably enhance enhance the treatment and reduce the recurrences. And this has been shown in previous studies. The choose between interferon alpha 2b versus tumor excision, sometimes if you have very diffuse and you are afraid that you might cause limbal stem cell deficiency, maybe interferon is preferable. If it is just localized lesion, it can be just excised. Dr. Jim Cameron has one single case that was purely in the cornea without any involvement of the limbus. So this proves that CIN can involve just corneal tissue without any conjunctival or limbal involvement.
Thank you. I think all these points are valid and highly appreciated. I think you are alluding to very important points. The use of alpha 2b, interferon alpha 2b, usually should not be restricted to large elevated tumors. You should do debulking, and in order to prevent, you can use it for CIN, but you cannot use it for tumors that are, you have to combine your therapy. And this is why I mentioned that you don't always do only excision or medical. You have to combine them, especially in large cases, large lesions. And the grading that Dr. Al-Qattan is alluding to is very important. I don't want to waste time in going over it, but I think as pathologists, it is very important for them. And they tell you, is it less than 5 millimeters or more than 5 millimeters? Then the grade can change depending on the level of the lesion. So I think the grading is also important in following up in the management especially.
Yeah, the staging is important in terms of size and the degree of differentiation of the cell type as well. Dr. Fawaz, yes?
Thank you, Prof. Khalid, for a nice lecture as usual. Just I have one comment regarding the xeroderma pigmentosum. I had the privilege to review the cases here with Dr. Rahel Al-Hussein, and we found out, as you said, they have high prevalence of or incidence of squamous cell carcinoma of the conjunctiva. more than 1/3 of those patients had conjunctival tumor for the conjunctiva. The other thing, the other comment is regarding the use of mitomycin. As you said, the interferon is a bit expensive and sometimes not available. We are using the mitomycin, and I use it for patient who is having large tumor and has good outcome with only medical treatment without oxygen. And I also had some cases who had oxygen with combined with mitomycin, and in both ways the outcome is good.
I agree with you, and I just want to conclude by telling our young ophthalmologists not to believe what is being published in Western literature, but we have to reflect and see what's happening here in Saudi Arabia. As you have seen, knee had no metastasis. Zimmerman, who is a referral center, had 2.3% metastasis. We have over 8% metastasis here in Saudi Arabia. So if it rains in Washington, don't carry umbrellas here. So we have to apply our own experience, and you have to look for our senior ophthalmologists and their expertise. Thank you.
Dr. Saad, can we allow one more question? معلش
طبعا.
بروف تبارك دكتور دهمش.
Thanks, Prof. Tabara, for this extensive overview of the topic. I have just few comments, if you allow me. Number one, about the pterygium for the young ophthalmologist. We teach the young ophthalmologist that pterygium, usually the epithelium is intact over it, while ocular surface squamous neoplasia, they lose the glistening appearance of the epithelium because it's epithelial disease. So one of the ways to differentiate between like abnormal or bizarre looking pterygium and the ocular surface squamous neoplasia with the slit lamp is to look to the appearance of the epithelium over it. Yeah. The other issue about immunosuppressive treatment, it has been few reports about the chronic use of topical immunosuppressive like steroids. They are a risk factor for ocular surface squamous neoplasia, BRIT40, chronic use, or uveitis cases, or after penetrating keratoplasty. So people should pay attention to this. The other issue about the invasive nature of the tumors in our country, I think because of the presentation, most of them, especially the picture that you showed to us, they are advanced. And if you review the AGCC staging, those invading the orbit, they are very invasive, and also most of the time they will have lymph nodes. So if those pictures didn't develop metastasis, I question even the diagnosis, because those cases are pretty advanced, involving the orbit and invading the surrounding structures. So I think the reason for being advanced in our country is because of the late presentation of the cases. Regarding the chemotherapy, now the treatment of ocular surface squamous neoplasia changed a little bit. So many people use the term of chemo reduction or chemotherapy and chemo prevention. So they will do chemotherapy alone as a solo treatment. In some cases, if the excision is difficult, like in structure difficult to excise, let's say if it's involving the most of the cornea, if you excise it, you will deplete the stem cells. So many people use the chemo reduction or chemotherapy alone. The other issue of the chemotherapy, there is three choices. The main three choices: mitomycin, interferon, and 5-FU. The strongest is mitomycin, and the weakest the interferon. That's why interferon should not be used like as a monotherapy less than 3 months. Should be used continuously, QID, for a minimum of 3 months if it's used as a monotherapy or chemo reduction, because it's weak, less toxic to the cornea, and usually the results come after a few months. It doesn't come immediately like mitomycin. The strongest one is mitomycin, but the toxicity of the cornea is very high. That's why if I have the choice to choose, I will start with the interferon rather than mitomycin or 5-FU, especially if the cornea surface or the surface of the eye is not healthy. And thank you again for this extensive review.
Good points. Yes.
Just I remember something while Dr. Saad was talking. I remember Dr. Riley, you remember him, our pathologist?
Yes.
Once I was discussing with him about one case of the squamous cell carcinoma, and he has mentioned to me, it's his personal observation that the more Bowman's layer is taken from underneath the lesion, the more it will become invasive. I'm not sure if anyone is aware of that, but just as I remember that when I was discussing with him about this case, Dr. Ali, do you have a comment upon that?
I remember a sad patient who is Yemeni who presented with lesion excised in one of the peripheral regions of the kingdom. And after excision, he came with recurrences, and then it was excised again here. And after excision, he had lamellar dissection as well as scleral dissection. And the surgeon decided to put a donut-shaped graft in the cornea. And that graft failed, so we ended by having to do penetrating keratoplasty, and we found some tumor cells penetrating the cornea, going to the iris. So this shows that it can penetrate. The cornea is usually resistant for any tumor cells. It's more than sclera. But if Bowman's is absent, it can go even beyond that to inside. And we excised the tumor from the iris without any exenteration or enucleation. And the patient had a good outcome without any recurrences. So the lesson from that, never put any corneal tissue or scleral tissue over a tumor because it might recur and be hidden under that grafted tissue.
Okay, you are right. From the histopathology point of view, anything that will alter the barrier, the normal barrier, as you mentioned, of the cornea, will help in the invasion. Like we have seen cases of squamous cell carcinoma in situ that went from the upper fornix or upper part of the conjunctiva over the cornea to the lower part of the conj without causing any invasion, versus recurrent cases where the barrier has been altered because of the previous dissection, and then these patients tend to get, with the recurrence, intraocular invasion. So there might be a factor that will affect this, plus, of course, the other factors that were mentioned. Yeah.
We ruled out mucoepidermoid in the 10 cases that we have reported. And usually you rule it out by staining with the mucicarmine or Elchian blue or PAS. And these were done
في الفراش كل حالك ما حدش.
طيب. إيه هذا خلاص الدس.
اي خلاص ما نحتاج.
الله لا يهينك. يلا افتحها.
دكتور هذا الليزر بوينت كنت بتأشر.
ايه
تأشر.
اصبر. ممتاز.
تمام.
Can we start please guys? Okay, shall we start? We have we have 5 cases. It's very simple exam or simple quiz rather than exam. The first case was presented by Dr. Tahir al-Bahrani. Most of you do not know him. And when I was looking for slides for you for the examination, I found these in my computer. It's very interesting. And rarely you find them. But the patient, this young male, he brought his mother to the emergency room. I don't remember for what, but however, when Dr. Tahir has examined him, the patient told him, Doctor, you know, I have itching, chronic itching of my eyes, especially the left one. And he said, as far as I remember, he noticed the eye is slightly, palpebral fissure slightly less than the right eye with some redness. So he examined him, the slit lamp, and that's what he has found in his lid margin. What is the diagnosis, please? And what would you do for it as a treatment? Oh, I gave them the, it's okay, it's okay. It's rare, but you know, you may face it one day. So it's very interesting. Okay? This is a 47-year-old. I am following her for more than 10 years. And she has this lesion. This is the left eye, and this is the right eye, and this is during the treatment. What is the diagnosis? She is now 47. When she came to me around 30 to 35 years of age. What is the diagnosis? And what treatment? It is very simple. Sorry? She is followed up at our hospital for these 2 lesions for a long time. ما اسمعك حمد. Her vision with these, it's around, with a correction, sorry, what's wrong with me today? With correction, it is around moderately high myopia, -4 to -3 cylinder, 20/40, 20/50. Her vision is fluctuating according to her treatment. Okay, none of you asked me a simple question, but however, I will not tell you. This is the 3rd case. This I have presented a few years ago, but because it's very interesting, this is when he's now 44 or 45 years old male. When I was following him, he was at the age of around 27, 28. His vision on the right eye, 20/300, 400, and the left eye counting fingers. That's in April 2001, and in the lower 2000 The three. You see, this is almost becoming more denser, and this one, the area is getting smaller. What is the diagnosis? Sorry? No. Sorry? ما اسمعك. No. He was on a lot of medications, but no effect. Remember, he is around 27 to 30 years of age when he was presented to me. They were followed, both of them, they were followed at KKESH for years before they come to my clinic. Okay? History of? Yes. This is a 31-year-old female. She's a known case of congenital glaucoma and congenital cataract. She underwent cataract extraction. She is aphakic since childhood, and she had the strabismus surgery. In 2010 or 11, she underwent rheumatogenic retinal detachment, and she had surgical repair of rheumatogenic retinal detachment with silicone oil removed later on. Then after almost a year, she developed thinning of the sclera, and Dr. Summer-Swalem, my God, Dr. Summer-Swalem has made a small dural patch for her, and she was doing fine. Then later on, she's starting to have it getting worse and more. What is the diagnosis? Congenital cataract, congenital strabismus, congenital cataract, and she has strabismus as well as rheumatic retinal detachment. In addition to that, she has a horizontal nystagmus, and that's why, because of poor vision. So it's not related to this. What is the diagnosis here after the scleral surgery? Retinal surgery. And what treatment you will give? Diagnosis, treatment. The last case, this is around 45 years old Saudi male. He's referred to us from Taif. The patient has a pterygium, and the pterygium was excised, and they used mitomycin 0.04. And he developed this scleral thinning. Why? And what's your management? It is very simple quiz. Sorry? History, he has a pterygium excision with mitomycin 0.04 milligram per ml. Okay, Shabab, no discussion, please. No discussion. No discussion, ya Shabab. This is the Last case, patient had a pterygium excision with mitomycin 0.04, had secret thinning, and he was referred to us. Why he has it, and what's your management? The second case, this patient has congenital cataract, and she underwent, she's a phakic, underwent the rheumatic cerebral detachment surgery of her left eye. She developed this thinning of the sclera, and she had, as you can see, a dural patch, small, it was very tiny, thinning, and later on it was progressing. What is the diagnosis and management? No discussion, ya shabab. At the back, no discussion, please. It's not a failing, I'm not going to fail you or not. Just I want you to think of it, please. This case, when he came to me, he's around 27 to 30 years old of age. He was treated by many modalities, and he was progressing to the worst. What is the diagnosis? Someone asked me, he has itching? He said, yes, he has itching. What is it? When he came to me, he was around 27 to 30 years of age. Now he's around 40, 44, something like that. This is another patient. She is a female. She's followed up at KKESH for a long time. She has been used on given topical treatment for a long time. What is the most likely diagnosis of these two lumps? And what's your treatment? This one, as I told you, the patient has chronic itching. And you can see the lids. Allah. It's very simple. Okay, can we have the papers, please? I hope your handwriting can be read. It's not as usual. Shabab? Anyone is left? I will not receive anyone after now. Okay, no more. No more patients. Thank you. Who volunteers to give me the diagnosis? Come on, guys, yes. Sam? Absolutely, you are correct. Yes, you can see the lice at the eyelash here, and you can see the nest here, where the egg is attached, firmly attached to the eyelashes. Yeah, it's rare, but you may face it. Now, this one I was going to give it to you, but I did omit it. I will talk to you about it later on. It is when it is affecting the eyelashes, it's called Thyriasis bulbibrum. It is the same pubic lice, and the treatment, a lot of the treatment, if you look in the literature, but the main thing is mechanical removal. And to me, when I was reading the articles, mechanical removal and cutting the eyelashes. So you will not give the chance to the lice to lay its eggs on the eyelashes. And sorry, guys. Every time I put my elbow here, yeah. The aim of the treatment is eliminate the lice and the eggs. This is the main thing. So do whatever you like. Some people, they use ivermectin, 200 micrograms, single dose, orally and repeat it. And most of these treatments are for the scalp lice, okay? But it can be used. And permethrin lotion or perolatum, 1%, BID for 8 to 10 days. And they said the perolatum, which is bitter-like, is much better than the lotion. There is one point I found in the literature, I like it. Use any inert ophthalmic ointment with a white or yellow paraffin base, such as a simple eye ointment, to suffocate the living lice. There is a lot, if you go to the literature, a lot of solutions and lotions to be used, but most of these are for the scalp. You can use it. Some literature, they said you couldn't use it over the eyelashes. You have to keep the eye closed for 10 or 15 minutes, then you wash it. Well, I don't guarantee that nothing will go in, but if it is resistant and you cannot get rid of it, you have to use one of these modalities. Because of itching, irritation. You mean the left eye? You lift the left eye? Yeah, because of irritation. Irritation. Okay, diagnosis here. Any diagnosis? Masma. Come on, guys. Even if you make a mistake, whatever. What's the diagnosis? That's why I brought this patient. I want to draw your attention to such cases. What is it? No? No. Ocular surface what? No. No, not at all. That's why I brought. I'm sorry. It's very simple. Masma. No. No, someone he said, huh? VKC. It's not only in children. This is benign keratoconjunctivitis. She was treated for years with topical steroid, topical optichrome, whatever you just name it. And still she was suffering. This is VKC. And if you can see here, after around 4 to 5 years of her treatment. Now this is the right eye and this is the left eye. You won't believe her vision is 20/30 in either eye with refraction. You won't believe it. Of course, minus cylinder. And, moderate cylinder and concave, -2, -3 cylinder, something like that. And she's 20, 30, and she's happy. I treated her with what? I gave her cyclosporine A and prednisolone orally in around 30 to 40 milligrams. Then I started to taper it gradually. And I kept her on maintenance 5 milligrams for more than a year. Then I started to reduce it until I could control her properly. Now she is well controlled without any oral medications, only lubricants and betadine. That's all. Of course, I have given her cyclosporine A for the corneal opacity, and she's still on that, but she's doing fine. The message here, please, don't think that severe VKC can be treated only with topical, even if it's a child. You have to give them a short course of steroid, children, and you have to monitor. Okay, the second case, where is it? Yeah, this one. What is the diagnosis? Sam? Yeah, almost, yes. Yes. It's atopic keratoconjunctivitis. This patient has a long story, but in short, as you can see, his corneas as being affected. So I was planning to do superficial keratectomy and to give him some treatment. And when he came for surgery, he was worse, especially the left eye. So I kept him in the hospital. I gave him oral steroid, and to me, he was doing great, and he was improving. Then we did for him superficial keratectomy when this cleared more than this. Unfortunately, his slides are lost because it's the old slides. You know, the slides with this photograph. I looked for them. I couldn't find them. However, and I did for him stem cell transplant in the left eye, here and there. I got it from his brother. And he was in cyclosporine A and prednisolone orally for years. He was doing great. The point is not here. The point, during treatment, his eye, the right eye was clearing. Can you see it here? I didn't touch it. And this is the one with the stem cell transplant. After this patient, I changed my mode of treating adult patients with VKC. I hit them hard with the steroid. So both of them are VKC. Now this is his vision lately. He was at 20/30 in either eye with a near refraction. But why he is his condition is regressed, I mean his vision, because he has keratoconus, and I have to stop the cyclosporine A because he started to have nephrotoxicity, and he is now in 2.5 milligram oral steroid every other day. Still, he is on it. And by the way, this is one of our colleagues, Dr. Al-Mahmoud, if you remember him, the Bahraini. He went to do a thesis about stem cell transplant. And he told me he is the only patient who had survival of the stem cell transplant. Do you know why? Because of the immunosuppressant agents I am giving it to him. All of the others were successful initially, but when they stopped the treatment, they failed. So you have to keep the patient almost lifelong on immunosuppressant. This is the second case. It's a VKC, or atopic keratoconjunctivitis. Now we go to this young female, the one which I have showed you, her slide. Where is it? Yeah, this one. What is the diagnosis? Come on, guys. Come on. It's very simple. Huh? ما اسمعك. Yeah, what do they call it? No, it's not necrotitis. And even though she was an immunosuppressant, she started to have melting. So I have to change her treatment to more aggressive. sorry يا شباب لأنه البارح جهزتهم. فحايس where is she? Yeah, here she is. I have to do, when I exposed the conch, she has a huge grayish area, not only in that localized area. So I have to do a huge scleral batch. The aim here of the scleral batch, she still have a Dylan here. If you can see, I am putting an arrow, which is not the key. This is a Dylan because it is elevated. She has elevated sclera. However, she's doing fine. But the main thing, which I want you, the point I want you to keep it in your minds, when you do a sclera batch, the secret of its success, close it with the conch. Cover it, عفوا. Cover it with the conch. If it's not well covered, it will fail. It will get dry and it will fail. So the main secret of successful scleral batch is not a big deal, scleral batch, if you know how to do it. It's not a big deal at all. But the main thing, cover it with the conch. Otherwise it will fail. And sometimes you can see here, if you concentrate, can you see this suture? Can you see it? This is suture. I'm closing it from anteriorly from here. I have to compress it over the glue. So where can I anchor my suture? On the cone. So if it is in place and it's not loose, keep it there. So another suture here. Okay. What is this? We said pterygium excision, mitomycin 0.04, and he was referred to us as a thinning of the sclera. What is it? Yes, why? This is the question. Why? Exactly. They use high concentration for long period. You should not exceed more than 2 minutes if you want to. And wash it vigorously. Wash the mitomycin vigorously after you finish before you close the conch. Otherwise, you will end with this one. This patient, I did for him scleral batch, and if you can see, this is the amniotic membrane. By the way, I like the burst. I don't like the interrupted for amniotic membrane. This is my way. I prefer. I make 4 interrupted, then I make a burst suture. And you can see the sclera is well covered here. Here you can see it, well covered. And the patient has a cataract. He hardly agreed to do it because his vision was dropped after the pterygium excision. And I did for him ECC, not phaco, ECC because it was very dense cataract. And this is the final. His vision 2040, alhamdulillah. Thank you very much. Any question? It is very simple things, but put it in your mind. Any questions, guys? Thank you very much. Thank you to you all. لا الله يعافيك. اوه نسيت. ممكن استعرض. طيب نصلي وناخذ بشيء نسيت موضوع. والله نتكلم والله بالي فوق لاني انا منام. طيب الشباب يدرون حق البرزنتيشن عندكم؟ اعلن.
We will start at 4 exactly for M&M inshallah.
بسم الله الرحمن طيب I'm Faisal Al-Dahash, fourth year resident. I'm going to present this M&M case, which is about culoplasty, a wound dehiscence of an implant. Let's see the start from the beginning of the case. It is a 72-year-old lady complaining of pain and decrease of vision for 1 day, came to the ER complaining of that, and she had cataract surgery 4 days before. On examination, there was no light perception on this eye that she's complaining of. +3 conjunctival injection, corneal abscess, open temporal wound with pus coming out. The impression was endophthalmitis, and the plan was evisceration. Okay. The next day, the evisceration was done, conformer in place, secured wound, no signs of infection, so the impression was doing fine, and the patient was discharged upon that. After 4 days, she came back to the ER, complaining of pain and redness in the same eye, which was eviscerated, and an implant was put there. There was permanent discharge, conjunctival gapping with exposed implant. So the impression was socket infection with wound dehiscence. For suturing wound dehiscence in the right eye under local anesthesia, exchange of implant and wound repair was done. So day 1 post-op, after the wound dehiscence repair and exchange of the implant, she was okay, and they were planning to discharge. Day 2, she was okay, and she discharged on day 3. So the admission diagnosis was status post evisceration in the right eye, socket infection, and wound dehiscence with exposed implant. Discharge diagnosis was the same. Surgery was revision of the wound and exchange of the implant. There was a note that there was a discharge and small area of exposure on the implant. She has significant socket infection with severe discharge, and the plan was to give her antibiotic and follow-up. So the problem was the readmission within 30 days because of a complicated implant, exposed implant and infection. So I'm going to talk about orbital implant in general, types of them, the implant trap, secondary implants, which mean not putting the implant at the same method surgery, but secondary surgery, which some authors advise to do in such an eviscerated endophthalmitis eye. And finally, I will talk about the implant exchange, which was done in this case. So what are the types of implants? There are porous and non-porous. So the porous advantage is that it will reduce the risk of migration, excrusion, and infection, improve motility, especially if picked later on. So there are 3 subtypes under the porous, which are the hydroxyapatite. Hydroxyapatite began in the mid-1980s, and the idea was, this is the hydroxyapatite. It was taken from the marine corals, the same material or component, and resynthesized, and it was found that it is a good option for orbital implant, but it has more cost and need wrap material. Why we need to wrap it? Because it's very rough on the conjunctiva. That's what I understood from reading the literature. Wrapping will facilitate even the implant insertion. We will talk about wrapping materials later on. Second thing is the mid-pore or polyethylene. It is synthesized and came after the hydroxyapatite. This is the mid-pore. It is less biocompatible, but however cheaper. Smoother surface for the conjunctiva, so less irritation. May need wrap material. Suture can be directly on the implant. Suturing the muscle, we can directly suture the implant, the muscles on the implant. Finally, the most recent was the aluminum oxide, or they call it the ceramic or bioceramic, used in ortho and dentistry for many years before. The previous slide was about the porous, now the non-porous. The non-porous, less used nowadays, may have decreased motility and greater risk of implant migration. The rectus muscle still may be sutured over the implant, and there are some types of this kind. One of them is the PMMA. Now, picked versus non-picked. What do you mean by picked? It is the needle or the attachment of the prosthesis with the orbit through a secondary surgery done after a few months to facilitate the movement. So when we use a PECT material, a PECT implant, the movement will be retained around 87% of the fellow eye. So 78% of the normal eye will be achieved, while the unPECT 50%. Complications, of course, it has complications. One of them is discharge, pyogenic granuloma, loss of the peg, or audible click. Magnetic pegging system has been introduced recently. Types of implants. Continuing the same subject, now I'll talk about the wrapping versus non-wrapping. There are advantages for the wrapping, as I mentioned, facilitate placement of the implant in the socket, facilitate precise fixation of the rectus muscle to the implant surface, may also provide a barrier function over the speculate porous implant. So when you cover it, it will be as a barrier against the speculate, like the needles or the heads, sharp heads of the implant itself. Prevent exposure, this is debatable. Advantage of unwrapped. Why some surgeons prefer unwrapped? Because simplify the procedure, decrease operating time, reduce the total cost, and avoid creating second surgery. Decrease the risk of disease transmission when you use an implant which is like from a donor sclera or dermis, acellular dermis. Another kind is the pericardium, autologous tissue graft, for example, the temporalis fascia. This is a photo of how they do the implant. For example, this is a dural matter wrapping of an implant. The other photo is the dermis fat, autologous dermis fat implant wrapping material. So the surgeon's preference was recorded in one study. So the most popular and commonly used implant was the porous. 43% of cases, hydroxyapatite, the second, and the non-porous implant was the least. This is according to one study survey. The PECs were utilized only in 8% of cases. A majority of implants were not wrapped, but of those that were, donor sclera was the most common used. Secondary implant. Some surgeons place the implant in a secondary stage after the initial evisceration, particularly in the setting of acute infection, like this case, believing that the rate of implant exclusion may be higher with primary implantation at the time of evisceration. In one retrospective study of 67 eviscerations with primary implant placement in the setting of the endophthalmitis, the rate of exclusion on the, or other complication was quite low. We will discuss this issue later when I show you some other studies. This study, talking about complications associated with secondary orbital implant, they studied 71 patients, and they found that there is a high complication rate in a secondary implant. So maybe this is the reason why in this case, or some other surgeons also, they do not prefer secondary implant. They do the implant in the same setting of evisceration, even if there is infection or endophthalmitis. Implant exchange. Situations to consider implant exchange: to improve motility, to increase orbital volume, to reposition a migrated implant, or to replace an exposed implant for a smaller or a new one, as some cases. This study about 6 cases of bacterial infection in porous orbital implant. I'm not sure in this case of the M&M which type of implant they used, but here they mentioned 6 cases as a case report for infection in porous orbital implant. 5 patients were hydroxyapatite. The other kind, if you remember the kinds of porous, was mid-pore. So 5 cases in the hydroxyapatite had infection, mid-pore only 1. This study studying the porous and non-porous orbital implants for treating the anophthalmic socket. It was a meta-analysis of case series studies. So the conclusion was that the porous or polyethylene implant showed lower chance of exposure than the bioceramic. Bioceramic is the same as the aluminum oxide that I talked about in the types previously. This study about evisceration with primary orbital implant in fulminant endophthalmitis, so maybe it is targeting the issue of our case. The purpose of this study was to compare the outcome of evisceration with primary orbital implant with and without fulminant infection. And the conclusion was that evisceration with a primary orbital implant is feasible option, so they did the right thing. Evisceration with a primary implant placement in patient with endophthalmitis. Here another study supporting the same thing. And thank you for listening.
Yes, I would like to make a small comment. When he started his presentation, he mentioned that the wound was it was fake. Am I right?
I'm not sure. There was no sufficient data about it.
However, the message here, please, you develop your own sense as a surgeon. When you have ever feeling that you need a stitch, I always tell the parents and residents who is taking me, when you have the feeling that you need to put a stitch, don't hesitate, do it. For 2 reasons. The first one, always, your feeling is correct. The second one, you are not losing anything. Put the stitch, you didn't even tell someone you can take it out. But it's embarrassment for you in front of the patient when you take him. Next day you said, oh, I'm sorry, I have to put the stitch. This is bad for you as a surgeon. So take it as a rule. When you have the feeling or you feel that your wound is not well sealed, even though there is no leak, but you are well, take my advice for this. The second thing, yesterday I did a secondary batch for a patient who has ECCE done elsewhere, and he had, I'm sorry for keeping you waiting. He had ECCE, and there was iris prolapse from the wound. And according to the fellow, they told him, or he was told, or he knew that his surgeon, he checked the wound, the IOP, they said it is normal and no leak. So kept him the same. The patient came with him this time. I did for him secondary batch, and the retina went in, they said the retina was blown out. He lost it out. So when you have a wound gathering, or you feel it's gathering, please, go with it. Okay? Thank you very much. Sorry.
It's okay. Assalamu alaikum, good afternoon. I will present the second case today. I'm Abdurrahman Abloushi, fourth-year resident. So our case, she is a 56-year-old Saudi female patient, known case of cardiac disease, seen as a case of immature cataract right eye, scheduled for phaco, PCIOL right eye under local anesthesia. Full ophthalmic examination was performed, IR calculation, sealed and cleaned by anesthesia and the medical and cardiology. Admitted informed consent was taken. So the patient underwent peribulbar block for the right eye, and during the surgery, while removing the pieces with the phacoemulsification, assisting by using of the chopper, accidentally the chopper went inside the nasal part of the posterior capsule and created a large PCR, and the nucleus dropped into the vitreous cavity. At that time, the primary surgeon, the consultant was the vitreoretinal surgeon, so in the same spot, he started bars plan vitrectomy. With the removal of the dropped nucleus, there was 2 large plaques, endolaser was performed, and they did silicone oil because of very large breaks at inferior PI. On the same day, the patient developed very high IOPs, around 57, seen by the retina team and the glaucoma, and the impression was retained viscoelastic. The glaucoma advised to keep the patient on regular Diamox and the topical alpha-ganzalatan and dorzolamide. The patient was not cleared for timolol or systemic mannitol. Second day, patient was comfortable. IB went down 26 on medications. VA was hand motion, deep anterior chamber, patent inferior PI, and flat retina under silicone oil. Seen by glaucoma team, they advised to taper the Diamox to BID, and her IOP was controlled. and to be discontinued after 3 days after checking the IOP once the patient discharged. On the 4th day, the patient was comfortable, IB was 16, VA was hand motion, deep anterior chamber, patent inferior PI, and flat retina. So the patient was discharged on the 4th day with the 2 weeks follow-up in the clinic. So I will talk briefly about the dropped nucleus during the cataract surgery. So the dropped nucleus is the loss of a part of the whole or whole length nucleus into the vitreous cavity. It is a known complication during the modern cataract phaco technique surgery. This was not really known in the area of ECCE. Most cases need reoperation with pars-plana vitrectomy in order to avoid the serious complications. And these complications commonly happened with the dropped nucleus. Vitreous opacification in 90% of cases, and this is the main indication to do BBV. Uveitis in 57%, glaucoma 52%, corneal edema, retinal detachment, and cystoid macular edema. So why the dropped nucleus occurring more with the phaco, not with the ECCE? Because while you are doing the phaco, the main wound is sealed with the handpiece. And with the positive irrigation that we have with the phaco, either we have a large or massive zonal dialysis, or commonly the BCR, large BCR, the nucleus will drop into the vitreous cavity because of the positive irrigation power. So the published incidence of the dropped nucleus ranged from 0.3 to 1.1%, and any cataract surgeon who has a reasonable cases volume will at some time experience a dropped nucleus. Therefore, anyone performing cataract surgery must have a detailed plan deal with these complications. So the risk factors documented for dropped nucleus is pseudoexfoliation syndrome, traumatic cataract, fellow eye with complicated surgery, previously vitrectomized eye, eye with the phacogenesis, dense brown cataract, hypermature cataract. It can cause rhexis extension, a very aged patient, intraoperative foveal iris syndrome with small pupil, a high ametropia, posterior polar cataract. So the preventive measures can be taken in any case is to have adequate pupillary dilation and to do a gentle hydrosection and to avoid hydrosection, especially in posterior polar cataract. So the early management started from the prevention, then the detection of the BCR or severe zonal dialysis early during the surgery. So early recognition reduced the chances of vitreous loss and the dropped nucleus fragments. Yes, doctor?
Why you don't hydrodissect obviously
Yeah, because the creation of the wave to separate the cortex. And sometimes they have defect, already defect or very weak capsule. Yeah. Yeah, sometimes it's because already it opened. Yeah. So usually we are not, or avoid hydrosection. Yeah. So the very important point while you are doing a cataract surgery or phaco to recognize the BCR. So what are the signs of BCR? So sudden deepening of the anterior chamber with slightly dilating of the pupil, sudden transiting of the appearance of the red reflex in the periphery, inability to rotate of previously mobile nucleus, excessive lateral mobility or displacement of the nucleus, excessive tipping of the one pole of the nucleus, partial descent of the nucleus into a more posterior position. So what you will do if you have a large BCR and you are starting, you start doing the phaco. So don't panic. It is recommended that once you have a large BCR, to remove the phaco. But before you move the phaco probe from the inside, you have to maintain the EC, because sudden collapse of the EC will prolapse the vitreous. So it is advisable to go with the paracentesis and inject dispersive viscoelastic just to keep the vitreous in place. So the next step, if the retained nucleus is small and no vitreous prolapse with adequate capsular support, you can take it, if you can, upon your comfort. But you have to take these points in your consideration. Primary objective is the retrieval of the nucleus. Retained fragment can be brought to the anterior chamber with using dispersive viscoelastic. Bottle height should be lowered and the vacuum should be reduced, and avoiding sculpting and rotating the nucleus, and avoid aspiration near to the BCR site. If the vitreous loss has occurred and you have a large piece, or still you have large nucleus inside the anterior chamber, it is better to convert the surgery to ECCE to remove the the nucleus and to do good anterior vitrectomy to prevent the drop of this large nucleus. In case of posterior displacement, sometimes the nucleus will be in the anterior hyaloid phase because the anterior hyaloid may be intact. So it is mentioned that you can try the posterior assisted levitation with using a Bars plana site with injection of the dispersive viscoelastic disc to push the nucleus, the large nucleus, into the anterior chamber, and you can take it later on. So if you don't have a vitreoretinal backup and you have easily accessible fragment, you should remove it. But don't fish for the deeper one, because if you fish, you will create a vitreous traction, retinal break, and later on the patient will present with retinal detachment. You should perform a good anterior vitrectomy to avoid vitreous prolapse, and you have to check the wound carefully. You should close the wound tightly with the sutures, and sometimes you may need mini sutures just to make sure that the wound is closed perfectly. This patient may go to another surgery and or vitrectomy. Prescribe frequent postoperative topical steroid and IOP lowering agents, and refer the patient immediately to the vitreoretinal consultation. So what are the advantages to do the surgery on the same spot if you have a dropped nucleus? It prevents the patient from going 2 surgeries, chance of postoperative raise in the pressure and inflammation are reduced, and save the patient for unnecessary anxiety. But what are the disadvantages? Sometimes you have to supplement the patient with the anesthesia, subtenon or peribulbar. Pupil is generally small and hampering the view, making the surgery a little bit difficult, and corneal edema itself sometimes is increased because the patient is exposed to the long surgery. So once you refer to the vitreoretinal, the surgery should be done within 1 or 2 weeks. You have to evaluate the patient fully, including visual acuity, full ophthalmic examination, and ancillary test like a B-scan. So what we can see in the B-scan, commonly we see that the nucleus is dropped inferiorly with a border looks hyperechoic a little bit comparing to the other vitreous. And if you have cortical material, it will be dispersed as hyperechoic, it causes snowstorm appearance in the B-scan. So inflammation and IOP should be controlled before the surgery. So what are the options that the retina can do? If you have a small fragment, less than 2 millimeter, and you have clear vitreous with no inflammations or controlled inflammation, you can observe this small piece. But if you have a large piece, it can cause moderate to severe inflammation or vitreous opacification. This is an indication to be removed. Or the piece that causes significant raise in the anteroocular pressure or associated retinal detachment, endophthalmitis. This is all are indication to be removed by the retina. So the retina, what we will do, usually all the retina surgeons are sharing the same principles, regardless of the technique they use. So they should do vitrectomy, they should remove the nucleus, they should do peripheral retinal exam to rule out any breaks, and IOL implantation. So Bars plana vitrectomy is a must. They should start with to clear the anterior chamber from any vitreous. Intravitreal triamcinolone could be used to visualize the vitreous clearly. All the vitreous detachment to the nucleus should be removed. Fragmatome is being, if you want to use the fragmatome, induction of BVD is a must to prevent the traction on the peripheral retina. So removal of the nucleus, either nucleus will be soft, like remaining of large cortical material, or it's hard. So if it's soft, it can be removed by the vitrectomy, by the cutter of the vitrectomy, with a low near 600 to 800 cutting, using of perfluorocarbon heavy liquid to protect the macula from the, these pieces can fall on the macula. And you can use all the light pipe to crush these pieces against the cutter. But if you have a hard pieces, you have 2 solutions, either to use a fragmatome or phaco-tip without sleeve, or you deliver the nucleus through the limbal wound. So if you want to use a fragmatome or phaco-tip without sleeve, you should do a good vitrectomy and separation of the posterior hyaloid, reduction of the fragmatome power by 5 to 10% may have good occlusion and prevent these pieces to fall on the macula. And using of heavy liquid perfluorocarbon can protect the macula from these fragments. It can be delivered from the limbal root using a PFCL just to make this species float in the anterior chamber, and you can use the limbal one just to deliver it out. The caution should be taken, a nuclear fragment tend to slips over this meniscus to the peripheral retina, so peripheral retina examination is a must when you use this technique. So after you remove the nucleus, you should do a good peripheral examination with indentation just to make sure there is no breaks to prevent retinal detachment post-op. And IOL choice depend on many factors. If you have a good sulcus, you can use either 3-piece or the more stable is the BMMA IOL, or you can do, if you don't have a sulcus, you can do a sclerofixated IOL or glue. AC IOL is also an option, but it's not in the top because of many complications, which is not the time to discuss at this time. Single piece IOL, we not use it in this case because usually we don't have a good support in the back, so don't put this IOL in the sulcus. If you have bag, small BCR and good support in the back, you can use it, but don't put this IOL in the sulcus because it has a lot of complications. This is the end of my talk. This is my references, and thank you.
Just do a few comments, please. He mentioned something which I like so much. He said, don't panic. And it's really, don't panic. It has happened. You cannot avoid it. So try to be quiet and try to think clearly and try to do as much as you can. So I like that point Dr. Abdurrahman has mentioned. Don't panic. You should stress on it 3 times. Don't panic, don't panic, don't panic. Once when I was just a new consultant, I had a VIP patient. I did for him phacoemulsification. He had helvetic keratouveitis. It was good control, and I had to do for him phaco. And I had general dialysis. Then, you know, I was a junior consultant, and he's a VIP, so I started, oh my God, what's going on? Then I noticed that I cannot do anything. Hey, I'm in panic. So I tried to convince myself, and I could, alhamdulillah, succeed equally. It has happened. I was talking to myself, Hamid, it has happened. What you should do? Then, when I quieted down and didn't feel it with me, and I put the capsule retention ring, and I put an IUL, 3 pieces, as Abdurrahman mentioned, which I like it so much, not a single piece, 3 pieces, and still I'm following the patient. He doesn't know what has happened, and he's doing fine. So that's very, that's why I tell you I like his point, because I passed this stage 1 time. It has happened, nothing happened. And the kinologue, I like it so much. It shows you even the filament. So try to use it all. And when you have any small amount, that's my opinion, any small amount of vitreous in the AC, don't give it. Thank you, Abdullah.
Thank you.
Thank you to you all. Not sure the whole. I give you the choice. Sure.
closing the auditorium now, but I have request without request. Whose will be in the CTR? I told him Umar, my partner. He said, okay, I will give it to Umar tomorrow. That's it. I can give them laptop for tomorrow. House, okay, everything is clear. House, okay, thank you. Yeah, please. Yeah, please. Don't forget to take the laptop from Mr. Mohammed Sinai. Huh? Yeah, yeah. Okay, what else you to say? What you want to say? What is this request? What is this request? Yeah, just call us. الله يسلمك.